for facial paralysis because they've really changed in the last 20 years. The things we do right now we weren't doing, and not everybody knows about it, not just in the SLP community, but even in the medical community. Neurologists, other ENTs might not know about some of these options, and I want more people to know about it. So if you have any questions, I am mostly used to talking to other surgeons. So if I'm getting too technical, just ask me to slow down or explain anything. And so at this point, let's talk about facial reanimation. Most of my patients after vestibular schwannoma, like Frank, like that picture that he showed us, immediately after his non-brain surgery, brain surgery, are now waiting to see what happens. So we want to wait and see if that facial nerve will recover by itself or if we need to do a surgery to reanimate the face. And in general, facial reanimation is either nerve transfers or free muscle transfers. And the nerve transfers are a lot better because in nerve transfers, we're able to restore your own nerves and your own facial muscles. And in free muscle transfers, we have to make new muscles that are gonna behave as facial muscles. And I'm gonna spend most of the talk today talking about nerve transfers and a little bit about free muscle transfers. I do combine this all the time with static suspension, with lifts of the cheek, of the nose, with eyelid weights or lifting of the lower eyelid. I'm not really gonna talk about that today. And for nerve transfers, there's a time expiration. So getting patients to come and see me early is super important. After a year, the nerves and the facial muscles are no longer able to be re-innervated by other nerves. At the longest, 18 months. And now we have more and more data that shows us that if we do this earlier, particularly in the first 6 months, our patients do a lot better. And this is a little bit different for children. Children might be able to do a little bit better beyond that. But to coordinate a surgery, I want to try and get the patients to see me as soon as possible. And today we've been talking about vestibular schwannomas, but this facial reanimation surgeries apply for any pathology that affects the pathway of the facial nerve. So starting in the motor cortex, going to the brainstem, to the cerebellopontine angle that we were talking about, traveling behind the ear, and then coming into the face. And as the facial nerve travels in the back of the ear and comes into the face, it splits into thousands of branches in over 10,000 axons to really get to the muscles in the face that are so delicate. In back 20 years ago, we used to try to restore all movement to the face. So reanimation tended to focus on the main trunk of the facial nerve. And now we know that having full contraction of the face is not really a restorative goal. So we concentrate on the branches in the midface that help us smile and elevate the upper lip. So zygomaticus major and minor. And nerve transfers are more and more becoming combinations of different options. So my favorite nerve transfer definitely is the mesenteric nerve transfer, which is right here on the left. So the motor branch of cranial nerve 5, and I'll talk more about that. We can also combine it with the contralateral facial nerve if the other side of the face is intact. And back in the day, there was a lot of hypoglossal nerve transfer, which fell in disuse, but it's coming back, and we'll talk a little bit about why. So I'm telling you that the masseter nerve transfer, the cranial nerve 5, is my favorite. So why is that? Well, it's technically meticulous surgery, but it's easy. The nerves are sitting right next to each other. It's a 2-hour outpatient surgery.
Wow.
It's very likely to result in a good outcome. So when done in the appropriate patient, 95% chance that they're gonna be able to smile again. And then the donor morbidity, like the deficit from me taking that nerve out of the masseter, is minimal. They will get atrophy of that muscle, and when they eat, the face will contract. But in general, that's really well tolerated. So we've seen Frank's case. This is Jean. She allowed me to share her name and photos. And she comes to see me after 8 months from her surgery for the vestibular schwannoma, completely paralyzed. I mean, you can see here I'm asking her to smile, and she does not look happy. Her brow is ptotic, her lower eyelid is down, the skin in the brow is bare, almost touching her eye, her nose is twisted, her lips and cheek, all of the things that we know are caused by flaccid facial paralysis. In the traditional teaching is we wait a year. We wait a year and we let those nerves grow. And I think a year is too long, that we really should be acting sooner. So this is a study out of Hopkins where I had the pleasure to train by one of my mentors, Kofi Bahini, and he took a group of patients that had a vestibular schwannoma, and the nerve was intraoperatively intact, but they had no movement after surgery. And those that had some movement, even little tiny twitches, those that are just giving us hope, but we don't really see it as meaningful movement at 6 months, they all went to recover really well without needing any surgery. But for those people that had no movement, no twitching, no anything at 6 months, they offered surgery with a masseter to midface transfer, so 5 to 7 in the midface. And those that took the surgery went to have a really great recovery. And those that didn't, that said, I'm just gonna watch it for the year, did not get any further improvement. So I tend to offer surgery a little bit sooner to my patients. And this is what surgery looks like. It's a small incision in front of the ear and extending onto the temple hair tub. Here's a zoom in as to where I'm connecting the nerves with suture. And then this is a little video which I hope you find interesting. And so the blue loop is around the masseter nerve, and then I'm pointing right now to the facial nerve. So that's a battery pack, so an electric stimulator. So when I stimulate the masseter nerve, you can see the muscle contracting, and they're right there. I just need to cut that nerve and bring it to that bigger branch that you're seeing right there, which won't stimulate because she's been paralyzed for 7 months. And then this are her outcomes. So hopefully these videos will go. This is her before, and then this is her after the surgery. And I did some static work for her eyes, but you can see that now she's able to smile. Sometimes the videos don't work, so this is just a backup. Okay, let's talk about cross-facial nerve graft. So I'm often using the contralateral facial nerve as an adjunct to supplement. Why? Because in a masseter nerve transfer, patients have to bite to get the movement. But if I can get the contralateral face to move the face, they can just smile and it'll go. So that's amazing and one of the great advantages of using a cross-facial, but it has a huge disadvantage. And that's that it's a pretty long path from one side of the face to the other. And it takes a really long nerve. Usually we take the sural nerve from the leg. That's, as we know, a sensory nerve. It doesn't cause any problems with movement of the leg. There's a little patch of numbness right there to find touch. And it will bring some movement to the face. By itself, it's likely to fail. Technology and our knowledge of anatomy is getting so much better. Here I'm stimulating normal facial nerve branches, and before you saw zygomaticus, now you're seeing orbicularis oris. So I can be really specific about which branch I'm taking, and it really does not cause any problems on the donor side. The other side of the face will move normally after we take that. So it's very common for me to combine a masseter with a cross-facial nerve graft. And this is a relatively young patient after a vestibular schwannoma, but here she's smiling without having to bite. She's just moving her face without cross-facial, which is something that I hope I can provide my patients. Sorry about that, I didn't mute that audio. Okay, let's go back to hypoglossal. So I think hypoglossal probably has a bad reputation in the speech and language community because of this. When it was first invented, the whole nerve was cut and it was brought to the facial nerve. And it caused horrible speech and swallowing difficulties. So luckily that's been modified. And nowadays we do partial hypoglossal transfers. The most common configurations being the drawings that I'm showing you here, where we either go and drill the mastoid behind the ear and we bring the main trunk to the hypoglossal so that we're minimally manipulating the hypoglossal, or we use a patch cable or a cable graft to connect the partial hypoglossal to the facial nerve. And Frank asked me to share what surgery he had done. So while I didn't perform this surgery for him, he was treated at UCSF by Dr. Daniel Nutt, who's an excellent surgeon. He had a masseter to facial transfer in a cable graft from ansa hypoglossy to another branch of the facial nerve. So this is having a research where we're combining more nerve transfers because we're able to take a smaller piece of the hypoglossal if we already have masseter in there. And it's amazing, like sometimes we'll see the tongue stay clearly at midline, even though I know I've cut 10-20% of the accents in there, and it provides us better tone and more accents that are coming into the face. And this is an example of a patient of mine who had a stroke in her midbrain, so she had no mass throat, she had no facial nerve, and then we did a hypoglossal, and you can see her smile. And I'm very cautious because this is a patient who should have never had a hypoglossal nerve transfer. He had a cavernous sinus hemangioma, so he was paralyzed from his larynx, he had vagus paralysis, he had facial paralysis, and a surgeon decided to go do a hypoglossal nerve transfer, which failed, and then he really was unintelligible, and you can see here the big deviation of the tongue. So we were able to help him with some static suspension, but even though I'm very cautious with it, I do like using partial hypoglossal, and I think you're gonna keep hearing about more use of partial hypoglossal with decreased morbidity for speech and swallowing. So this slide here is to remind me to talk to you about the time and how difficult it was for Frank to advocate for himself. So this is a needle EMG that Frank is getting done right here. And he asked for it, he requested it because he was seeing no recovery. And in general, if I understand, the medical field was kind of telling him, no, don't do it, you don't need to do it, just keep on waiting. And so that's really heartbreaking for me because I want the doctors to be advocates for our patient care, and ideally I want to see anybody who's flaccid within 6 months of their flaccid paralysis so I can talk to them about options. And so while I spoke more in depth about the nerve transfers, I wanted to just say that if somebody is beyond that 1 year, that they're no longer candidate for nerve transfer, we still have options for them. So this is that surgery that I was telling you about where we take a muscle from the leg and we shape it and make it into a facial muscle. And this is a patient with cancer actually, but you can see here what we were able to do to restore her facial movement and smile. And then there's also a large group of patients that have some recovery, but their recovery is incomplete. And for these patients, even though I don't have the time and space today to go into it, we have options like insurance cover Botox, like some surgeries that can help us improve their facial movement and can make a really nice, meaningful difference for their lives. So with that, I'm gonna hand it back to Frank.